Good morning, good afternoon, and good evening, everyone, depending on where in the world you are. Welcome to our webinar on Moving Beyond ICPD, a collective vision of sexual and reproductive health, rights, and justice. We'll be starting in just a minute. At this time, you should be able to see the first slide of our presentation. And if you can't see that, please use the chat box to let us know. And again, we'll be starting again in just a few minutes. All right, hello everyone, and welcome to our webinar on Moving Beyond ICPD, a collective vision of sexual and reproductive health, rights, and justice. We're going to get started now. Please use the chat box at any time to notify us if you have problems hearing or seeing our presentation. We'll take time for questions and discussion after all our presenters have finished today, so please wait until then and you'll be able to ask your questions or share comments via the chat box. Please also note that this webinar is being recorded so we can share it with our colleagues who couldn't join us today. Okay, so now I'd like to introduce Patty Skooster, Ipas's Senior Policy Advisor for Technical Innovation and Evidence, who will get us started. Patty?
Hi, everyone. I'm so glad to be here. I'm Patty at Ipas, and I have the privilege of moderating this webinar and also introducing our incredible speakers. As Jen said, all of the questions will be taken at the end, and we'll do that via the question box, and I'll read the questions aloud. So welcome, everyone, as we recognize both the 25th anniversary of the International Conference on Population and Development and the 25th anniversary of the reproductive justice movement amid tremendous challenges in U.S. policy, both foreign and domestic. We're here together to contemplate a vision for the future of sexual and reproductive health, rights, and justice, and to consider the work of the GUTTMACHER-LANCET Commission on Sexual and Reproductive Health and Rights. We're very fortunate to have gathered these 4 speakers who will present their thoughts and ideas on moving beyond ICPD and toward a shared understanding of frameworks for sexual and reproductive health, rights, and justice for both foreign and domestic policy advocacy. So our speakers. First up is Dr. ANU KUMAR, President and CEO of Ipas, where she provides strategic leadership for over 500 staff in more than 20 countries, all guided by Ipas's commitment to working for a world where every woman and girl can determine her own future. Since joining Ipas in 2002, ANU has been a thought leader for the organization and the field overall on topics such as abortion, stigma, gender equity, and sexual and reproductive health and human rights. Prior to joining Ipas, ANU worked at the MacArthur Foundation and WHO. Next, we'll hear from Dr. Jane Bertrand, professor in the Department of Health Policy and Management in the Tulane School of Public Health and Tropical Medicine. Jane's interests involve program evaluation and behavior change communication in the areas of international family planning and HIV prevention. From 2002 through 2009, she directed the Center for Communication Programs for Johns Hopkins Bloomberg School of Public Health, and her published research focuses largely on Latin American and Sub-Saharan Africa. Jane also served as commissioner on the GUTTMACHER-LANCET Commission on Sexual and Reproductive Health and Rights. Our third distinguished speaker is Marcella Howell, the founder and president of In Our Own Voice, National Black Women's Reproductive Justice Agenda, a national state partnership with 8 Black women's reproductive justice organizations with a goal of lifting up the voices of Black women leaders on reproductive rights, health, and justice. With over 40 years experience advocating for women's rights, reproductive justice, and women's empowerment, Marcella is devoted to enhancing the role of Black women in national policy debates on issues that impact their lives. And she was formerly the Vice President of Policy, Communications, and Marketing at Advocates for Youth. Finally, we'll hear from Bjorn Roos-Snyder, the Director of Public Policy at Change, where she oversees the organization's work to promote sexual and reproductive health and rights within U.S. foreign assistance. And in her work, Roos-Snyder creates coherent and responsive advocacy strategies for a myriad of issues related to reproductive rights, human rights law, HIV/AIDS prevention, and education, advocacy, and foreign policy. And she's our legal expert on the implications of the global gag rule. So thanks again, everyone. This is really a star-studded cast here at our webinar. I'm so delighted to be moderating, and now I'll turn it over to Anu.
Thank you, Patty. And let me start by thanking Change for their partnership on this webinar and staff at Ipas and Change for their work in organizing this. It is timely. In 1994, I had the pleasure of attending the International Conference on Population and Development, or ICPD. And at the time, I was quite shocked to find that the right to safe legal abortion was still being debated. Really, I thought. Coming from the United States, I naively thought that Roe v. Wade had settled all of that in 1973. As you know, at ICPD, the world recognized that women are at the center of development, and that sexual and reproductive health is a critical ingredient in the process of development. At the conference, 179 countries agreed to the ICPD Programme of Action and committed to the definition and realization of sexual and reproductive health and rights. Governments committed to making reproductive health care, including family planning, maternal health care, and abortion services accessible. But fast forward to 2019, and the right to safe legal abortion is still not settled. In fact, in the United States, it's being stripped away one state law or regulation at a time. Next slide, please. The truth is, access to abortion is and always has been precarious. In the United States and around the world, poor and minority people, young people, and those living in rural areas are most affected by lack of access to abortion care and discriminatory enforcement of criminal abortion laws. And several US policies reinforce that discrimination. We have the 1973 Helms Amendment still in place, and the 1976 Hyde Amendment, both essentially preventing women living in poverty from getting abortion. Helms prohibits the use of foreign aid for abortion, while Hyde prohibits federal funds in the United States for abortion. I know this isn't surprising to many of you. Women of color have been highlighting the intersections of class, race, and gender when we're talking about sexual and reproductive health and rights since the time of the ICPD in Cairo. So back in 1994, I was, of course, much younger and impatient. Now I'm older and I'm still impatient, and I find myself looking at social change, though, from a very different lens. Instead of thinking only in election cycles or court cases, or even from the point of view of legislation, I'm thinking that we should measure progress with a longer view, perhaps using a generational scale. So if we look, for example, at the movement for women's suffrage in the United States, that movement began in 1848 in upstate New York, and women did not win the right to vote until more than 70 years later. And it was a battle that brought together women of differing races, religions, and socioeconomic status. And for many of them, it landed them in jail. They had to work through serious differences within their movement over whether, for instance, the vote should be extended to white women only. But they persisted, and the 19th Amendment was finally ratified in August of 1920. Similarly, the fight for comprehensive sexual and reproductive health and rights also needs to bring advocates together across countries and regions and across different experiences to ensure reproductive justice is achieved for everyone, no matter where they live. Next slide, please. So if we look at change from this perspective, there is no denying that abortion rights are advancing. Since 1994, roughly 40 countries have liberalized their abortion laws. With safe, legal abortion more accessible, the number of deaths from unsafe abortion each year has gone from 70,000 to 44,000 over the past decade. After abortion laws were liberalized in Romania, South Africa, and Bangladesh, for example, researchers found a reduction in the number of deaths related to unsafe abortion. And in recent years, we've seen dramatic changes in Nepal and Ethiopia. Progress means that we now understand better the links between reproductive health and rights on the one hand and sexual health and rights on the other. We know that sexual and reproductive health and rights are linked, and they're linked to issues such as bodily autonomy, maternal health, and equality. So we're making progress, but why isn't it faster? The change that we're seeking involves women's rights, women's bodies, and control over our bodies, and I think this is deeply threatening to the social order. Abortion is the tip of the spear into the heart of patriarchy, which is precisely why it draws so much opposition. And there are many dimensions to abortion: political, medical, legal, but at its core, what we're after is a fundamental change in the way men and women have interacted and behaved for thousands of years. And that's not going to be quick or easy. So I think we need to play the long game. And as Americans watch abortion access shrink under the Trump administration, we need to remember that the United States is an aberration in the global march for women's rights. And the global movement, from Ireland, which voted to end its near total ban on abortion, to Northern Ireland, which on a single day ended its bans against abortion and gay marriage, to countries such as the Democratic Republic of Congo, where historically restrictive abortion rights have been expanded, all of these examples can provide American activists with ideas and inspiration. Just look what happened in Nepal, where abortion was illegal until 2002, and hundreds of women died from unsafe abortions each year. Today, women and girls in Nepal have the right to access safe, legal abortion free of charge at public health facilities. In Rwanda, the government recently expanded the legal grounds for abortion and also pardoned 367 women and girls who had been jailed for abortion. Next slide, please. What we need now is to come together, those of us who work globally and those that work in the United States. And I think the Guttmacher-LANCET Commission report actually gives us an excellent way of coming together and organizing. It is a roadmap for moving beyond the promises of ICPD. I think this consensus can be used for advocacy in the United States and abroad, and I think it would help us all to do a better job of maximizing our resources and working together. The Guttmacher-LANCET report begins with a comprehensive definition of sexual and reproductive health and rights, which was first articulated actually at the ICPD in 1994, and describes sexual and reproductive health as, quote, a state of physical, emotional, mental, and social well-being in relation to all aspects of sexuality and reproduction, not merely the absence of disease, dysfunction, or infirmity. The Commission's approach integrates sexual health, sexual rights, reproductive health, and reproductive rights into a comprehensive definition. And our next speaker, Jane Bertrand, will talk more about this. Next slide, please. Essentially, we can't improve health until we advance rights. We have to break down our silos. We have to come together to move beyond the ICPD. We have to think and work intersectionally, combining international and grassroots all at once. And I think we need to focus on our end goal and build a collective vision of what sexual and reproductive health and rights and justice will look like for everyone, whether you live in Nepal or in North Carolina. Thank you for listening, and now I'm happy to turn this over to Dr. Jane Bertrand.
Thank you, Anu, and thanks for the opportunity to present the highlights from the report of the Guttmacher-LANCET Commission for Sexual and Reproductive Health and Rights. Next slide. The Guttmacher Institute partnered with Lancet and the African Population and Health Research Center to create a commission on sexual and reproductive health and rights, reflecting a joint vision of a world in which all people are able to exercise their rights and responsibilities regarding sexual behavior and reproduction, freely and with dignity. The commission consists of 16 experts from regions around the world with multidisciplinary experience in a broad range of issues related to sexual and reproductive health and rights. The Commission's final report, which was published in the Lancet in May 2018, highlights the enormous gaps in sexual and reproductive health and rights that exist around the world, and it quantifies the toll those gaps take on individuals, communities, and economies. The Commission challenges the limited view of sexual and reproductive health and rights, which I'll refer to as SRHR, put forward by the Sustainable Development Goals, proposing a bold and comprehensive vision that aims to address SRHR needs of all people across their life course. And the Commission asserts that realizing sexual and reproductive health and rights is essential to achieving human rights and development goals. Next slide. Before going into more detail about the recommendations of the Commission, I'd like to offer a brief overview of the report. First, the report presents a comprehensive, integrated definition of sexual and reproductive health and rights, including an essential package of sexual and reproductive health interventions. Second, the report includes an analysis of the global context and trends, including changes in the size and composition of populations, the legal, social, cultural, and economic factors that influence sexual and reproductive health and rights, and recent developments in technology and innovation. Third, it presents the latest evidence on existing gaps and needs for SRHR. Fourth, the report highlights that some populations have distinct SRHR needs that go unaddressed, including adolescents and people with diverse sexual orientations, gender identities, and sex characteristics, as well as refugees and those living in humanitarian crisis settings. Fifth, the report details the investment case for sexual and reproductive health, including the costs of providing relevant health information and services and the benefits that result from doing so. Six, the report ends with identifying high priority areas of action to create an enabling environment for improving SRHR. Next slide. The report concludes with 8 recommendations for national, regional, and global policymakers, health practitioners, educators, and health and rights advocates. 2 key recommendations support action on adopting and applying a new comprehensive vision of SRHR and progressively expanding access to an essential package of sexual and reproductive health interventions. The Commission concludes by calling for sustainable financing and support of sexual and reproductive health and rights, and for ongoing accountability to ensure the global community and national governments meet their financial and health services goals. Next slide. One of the key contributions of this report is the view that sexual health, sexual rights, reproductive health, and reproductive rights are distinct but interlinked components, and that SRHR must be addressed as an integrated whole. The first global agreement that created common language around this issue, as Anu pointed out, was the Programme of Action of the International Conference on Population and Development, held in Cairo in 1994. It defined sexual and reproductive health and reproductive rights, but it did not use the term sexual rights. Over the past 20 or 25 years, language around sexual and reproductive health and rights has evolved considerably, but none of the ensuing United Nations agreements have gone far enough, and none have used the term sexual and reproductive health and rights. Next slide. At its most basic level, the WHO's commonly accepted definition of sexual and reproductive health is a state of physical, emotional, mental, and social well-being in relation to all aspects of sexuality and reproduction, not merely the absence of disease, dysfunction, or infirmity. The Commission's definition reflects an emerging consensus on the services and interventions needed to address the needs of all individuals. It recognizes that improving sexual and reproductive health depends on advancing sexual and reproductive rights. The Commission report is based on evidence, but grounded in human rights principles, and it lays out the sexual and reproductive rights of all individuals to have their bodily integrity, privacy, and personal autonomy respected, to freely define their own sexuality, including sexual orientation and gender identity and expression, to decide whether and when to be sexually active, choose their sexual partners, and have safe and pleasurable sexual experiences, to decide whether, when, and whom to marry, to decide whether, when, and by what means to have a child or children, and how many children to have, and finally, to have access over their lifetime to the information, resources, services, and support necessary to achieve all of the above, free of discrimination, coercion, exploitation, and violence. Next slide. Related to and part of the definition, the report also proposes an integrated package of essential sexual and reproductive health interventions. This proposed package mirrors the components of the comprehensive definition and includes interventions related to the key areas of sexual and reproductive health that are discussed in the report. These include prevention and treatment of HIV/AIDS and sexually transmitted infections, infertility, and reproductive cancers, counseling and service for a range of modern contraceptive methods, care during pregnancy and childbirth, including postnatal and newborn care, safe abortion services and treatment of complications from safe abortion, and prevention, detection, and counseling for gender-based violence. Next slide. In addition, the package includes the provision of information, counseling, and services for sexual health and well-being, as well as comprehensive sexuality education. The Commission recommends that national, regional, and international policymaking bodies, multilateral organizations, and stakeholders across the health and human rights sectors adopt and apply this comprehensive definition with specific attention to sexual and reproductive rights. Recognizing that national health systems are at varying stages of development, a stepwise approach may be needed, with countries determining their priorities for the short term while making institutional reforms to lay the foundation for future progress. Priorities must be set and trade-offs are inevitable, but equity should be a core value. Next slide, please. Based on the review of the evidence, the Commission recommends that key gaps in sexual and reproductive health services and programs be addressed. These include providing access to safe abortion care, ensuring that adolescents have access to sexual and reproductive health information and services, addressing sexual and gender-based violence through policies, services, and prevention programs, and engaging men to support women's health, rights, and autonomy, as well as addressing men's sexual and reproductive health and rights needs. Next. The Commission also highlights the need for additional support for groups that are often marginalized, disadvantaged, or subject to discrimination. These populations vary from one country to another and include those that are often the hardest to reach, including the poorest people in rural areas or in urban slums, racial and ethnic minorities, people with disabilities, sex workers, people who inject drugs, and street children. In addition, it includes displaced and refugee populations, often in the context of humanitarian crisis settings, and people of diverse sexual orientations, gender identities and expression, and sex characteristics. Next page. We need more research. First, on many, if not all of the groups just listed, to more fully understand and document their SRHR needs and the challenges they face in obtaining care. Other topics that are often hidden from public view and rarely acknowledged or discussed include gender-based violence, abortion, and sexual health and well-being. Next. The Commission recognizes that advancing SRHR requires improvements in healthcare and also depends on changes in the enabling environment. The report includes a recommendation on addressing the social, cultural, legal, and economic barriers, including those that are gender-specific, that prevent people from fully achieving their sexual and reproductive health and rights. A few examples include banning child marriage, promoting gender equality and women's autonomy, liberalizing abortion laws, and protecting the rights of lesbian, gay, bisexual, queer, and intersex people. Next slide. The report makes this case for greater investments in SRHR and recommends securing sustainable domestic and international financing to close the gaps that exist. It calculates the cost of addressing a large portion of the overall SRH needs, which include specifically contraception, abortion, maternal and newborn health care, at just $9 US per person per year in developing regions. This is an affordable investment, especially considering that half of this amount is already being spent to cover the cost of current levels of care. It will yield enormous results. Next slide. In closing, I'd like to speak briefly about some of the concrete outcomes the Commission hopes to see from this work. The adoption and promotion of this bold new agenda and use of the comprehensive definition by the SRHR community, for example, the World Health Organization, UNFPA, NGO advocacy groups, to name a few. A greater understanding and acceptance of the centrality of SRHR to the broader health and development agenda, for example, in determining the services to be provided as part of universal health coverage. Incorporation by governments and UN agencies of the essential package of sexual and reproductive health interventions in their policies and programs, and increased investment in sexual and reproductive health and rights by governments, donors, and the private sector. Next. Lastly, I'd like to underscore that all of the Commission's resources are freely available online, and we encourage you to download and share them widely. The full report is available on Lancet's website, free of charge, and the executive summary is available in 8 languages on the Guttmacher Institute's website. Next slide. Finally, we would like to thank the multiple funders for their generosity, next slide, in the support of Guttmacher-LANCET Commission. Now I'd like to pass the microphone to Marcella Howell.
Thank you. Marcella Howell here, and I am the founder and president of In Our Own Voice, National Black Women's Reproductive Justice Agenda. And I've been asked to talk about how this new definition impacts on reproductive justice and how we exercise and activate around reproductive justice in the United States. As was mentioned earlier, this is the 25th anniversary of reproductive justice, as well as the 25th anniversary of the ICPD. In June of 1994, before the ICPD meeting, Black women gathered in Chicago, 12 Black women, and really looked at what they thought the ICPD and at that point the women's movement and how it addressed the needs of Black women. And what they concluded in this meeting was that the women's rights movement, led by and represented by middle class and wealthy white women, could not defend the needs of women of color, specifically Black women and femmes and trans women, and that we needed to actually lead our own national movement to uplift the needs of, in this particular case, Black women. The women also then coined the phrase reproductive justice. Next slide. And reproductive justice, in terms of a definition, put together reproductive rights, which everyone wanted, and social justice, and that equaled reproductive justice. And they did that specifically to approach reproductive justice from a human rights framework that had been adopted in the United Nations international concepts. Next slides. Reproductive justice as a definition is the human right to control our bodies, our sexuality, our gender, our work, and our reproduction. And that right can only be achieved when all people have the complete economic, social, and political power and resources to make healthy decisions about our bodies, our families, and our communities in all areas of our lives. Next slide. At its core, reproductive justice is the belief that all people have the right to have children, the right to not have children, and very importantly, the right to nurture their children in a safe and healthy environment. And I'm going to have them play a video for you that sort of defines reproductive justice in all of its frames. Can you play the video now? Oops.
Reproductive justice. A lot of people talk about it, but many don't know what it really means. Here's the basic idea. Coined by 12 Black women in June of 1994, the term is the combination of two phrases, reproductive rights and social justice. The new phrase reflected the lives and experiences of Black women in the United States who had been denied a full range of services and protections. Black women have multiple identities, like age, ability, sexual orientation, immigration status, religion, and nationality, just to name a few. Consider the fact that Black women experience some of the highest rates of poverty and only make 63 cents for every dollar a white man makes. Nearly 20% of Black women have no health insurance and die 4 times as often as white women from pregnancy-related causes, regardless of income or educational status. The issue at play here is intersectionality, a term coined by legal scholar Kimberly Crenshaw, which refers to how multiple systems of oppression work together. Reproductive justice is how we take on all the systems that harm us. Reproductive justice is the human right that can only be achieved when all women and girls have the complete economic, social, and political power and resources to make healthy decisions about our bodies, our families, and our communities in all areas of our lives. Reproductive justice centers the leadership and lived experiences of the most vulnerable, including but not limited to Black women, women of color, LGBTQ people, and youth. So there you have it. Reproductive justice has given thousands of women a framework to change policy, improve services, collaborate with other social justice movements towards our collective liberation. For more information, contact In Our Own Voice at www.blackrj.org. Thanks for watching, and welcome to the movement.
So can you go to the next slide? Okay. So in terms of the new definition of sexual and reproductive health and rights, those of us who work in reproductive justice welcome this. I mean, it is a great addition to where we have been in a long, long time in the United States in terms of pushing reproductive justice. It is grounded in human rights, similar to the framework used for reproductive justice. It helps us think more holistically about the issues that impact our lives. It is rooted in bodily autonomy, which is an essential foundation for reproductive justice, in that it says that every person has the right to make those decisions about their body, and that encompasses all kinds of issues around reproductive health, rights, and justice, in that it places that decision-making power in the hands of the individuals and literally attempts to eliminate stigma, discrimination, and other pieces. And that it also lifts up the pleasure of sexual relationships, the next slide, and promoting self-esteem. However, when we come to looking at this definition and linking it into the United States, there are other factors that come into play. It is great to have the right to have an abortion, the right to get family planning, the right to exercise decisions about your own body. However, what we have in the United States is that having the right without the access to exercise that right means you have no right at all. Earlier, Anu mentioned the 19th Amendment and talked about winning the right to vote and the passage of the 19th Amendment, and the fact that white women and Black women worked very hard on trying to get the 19th Amendment passed. But the history in the United States is that once the amendment was passed and women got the right to vote, states systematically set up barriers for Black women being able to exercise that right. And that those barriers stayed into place, some of them based on violence and intimidations, but others just based on being able to answer questions that were ridiculous questions that were asked of people who came to register to vote, like how many counties existed in a state and what were their names, or just a range of questions that people knew that you could not answer. And even as you got through some of those questions, they just made up new questions to ask you that white women and men were not subject to. So that it took longer until the Voting Rights Act was passed that Black women and other women of color actually got the full right to vote. And we are still fighting that right, as we've seen as more and more barriers are continuing to be set up. So as I said, having the right to something does not really work if you have no access to it. Next slide. And this is where we come to intersectionality and what does it mean? Reproductive justice has always worked around the intersections of class, race, and gender. But being intersectional also means seeing the direct connections between sexual and reproductive health and rights and environmental factors, economic issues, gender-based violence, the criminal justice system, housing, food disparities. All of those things come into play. It is not just the social, cultural, and legal and economic barriers, but in the United States, we have the overlay of systemic racism that also comes into play. Next slide. So when we look at these things, we have to actually understand that decisions we make about sexual health are not done in a vacuum. Factor in the lived experience, which for Black people in America includes factoring in systemic racism. In short, we have to acknowledge that one side can never fit everyone, and that we have to make a commitment to factoring in the experiences of the people that we are addressing. Next slide. About a year ago, we actually did a poll of Black women where we asked them at any time in the past, have any of these things been part of your thinking on decision making about whether or not to have a child? And there were certain things that you would expect, like people talking about having a good job, having savings in their bank account. But we also saw that people were saying that they also looked at the safety of their neighborhood. 65% said that. Another 63% said having access to quality and affordable health care. Next slide. Additionally, people said that, could you go to the next slide, please? People also said that they were concerned about having access to healthy and affordable food options, or they were concerned about over-policing of Black communities, or the state of the their physical neighborhood and whether or not they were getting good services like trash cleanup and potholes being fixed. 50% of the women said they were also concerned about having access to clean water. Only 42% said they were concerned about having access to affordable birth control. And 33% talked about having access to affordable legal abortion care. So that there were all these other factors that came into play when they were thinking about whether or not to have a child. And it is those other factors, if you look at them, that are about the conditions that Black women often have to live in America. Can you go to the next slide, please? During that same poll, we asked people the question of, do you think racism affects the Black community's ability to do any of these different issues? And the percentage that said yes, for instance, 78% said racism affected their ability to feel safe in their own neighborhood. 74% said that racism affected the ability for them to have access to quality, affordable health care. Next slide, please. They also said 71% said that they were concerned that racism impacted whether or not their neighborhood got clean enough services like cleaning up trash and fixing potholes and fixing the state parks and whether or not they even had parks. 70% said that racism impacted keeping their children safe from over-policing. 68% said that racism affected them having access to healthy and affordable food options. 63% said racism impacted them having access to affordable legal abortion care. And 62% said it impacted on whether or not they had access to affordable birth control. 57% said racism impacted whether they had access to clean water. And if you think about what has happened in Flint, Michigan, and multiply that across the country, that Flint, Michigan was probably one of the most egregious incidents of not having clean water in a low income, predominantly Black community, but it exists across the board. And so it is those kind of things that when we look at the definition, next slide, please, and you ask people about how they make decisions about having a child, that the same issues come up. And then what is overlaid on that is systemic racism. And so those kind of issues are things that have to be factored in as we look at this new definition and try to take a definition that was specifically created for global work and then try to bring it into to domestic work in the United States and how it impacts communities of color and in their decision making and how they feel they can make decisions. And when we talked about having, earlier there was a map that showed that the United States showed that abortion was legal in the United States, except that when you try to access it. And in a lot of the southern states where the Black women predominantly live, there are all kinds of laws that prevent Black women from accessing abortion care. There are issues that range anywhere from what they have to go through in terms of travel, in terms of childcare, in terms of actually being able to access abortion services in their own community. So there are a number of factors, and as I said, we really applaud the fact that the Guttmacher-LANCET Commission came up with this expanded definition. It is an expanded definition that fits very well with reproductive justice and how we frame the aspect of bodily autonomy, but it doesn't go far enough when you try to bring it into a domestic setting in the United States. So now I would like to turn this over to Baron Ross Snyder, who will continue.
Thank you, Marcella. As mentioned, I'm Baron Ruth Snyder. I'm the Director of Public Policy at this Center for Health and Gender Equity Change. And I am going to be talking a little bit about how we get from the Lancet-Guttmacher definition to a blueprint for sexual and reproductive health rights and justice in the United States. Next slide. And I'm really pleased to sort of be representing civil society in the United States to a certain extent on this major project to, for the first time, put forward a public blueprint for policy advocacy and a vision of what sexual and reproductive health rights and justice can look like that doesn't dichotomize domestic and foreign policy. And this is really important because even amongst advocates in the United States, there's a pretty significant coalition divide in who is working on policy, law, regulations for the domestic sort of US-based constituents and who's working on foreign assistance and how sort of ICPD is being expanded to the world through the United States as a really significant actor in both foreign policy and global health. The blueprint is a many months long, pretty much a year, collaborative process that culminated in the release of the blueprint in July of this year. It was led by In Our Own Voice and Planned Parenthood Federation of America, and it's been endorsed by over 80 organizations, including Change and Ipas. And you know, most of those 80 organizations expended a lot of time and energy in shaping the policy asks and how they all fit together. Next slide. And this is the vision for the blueprint, that it's a proactive policy agenda in expectation and hope and prayer for a fully supportive Congress and administration coming in the future. And what this kind of proactive policy agenda, bridging domestic and foreign policy, can look like to advance sexual and reproductive health and justice in the United States and around the world. Next slide. So the blueprint is distilled down to 5 principles. It in those 5 principles, it contains a number of policy asks, both for the next administration and future Congresses, fitting them within these 5 principles of ensuring sexual and reproductive health care is accessible to all people, ensuring discriminatory barriers are eliminated, ensuring research and innovation, ensuring health rights, justice, and wellness for all communities, and ensuring that judges and executive officials advance sexual and reproductive health rights and justice. And some of the things that are really different about the blueprint, in addition to being very proactive and building out a vision, is that it really works to go beyond the binary in thinking about the ways that everybody experiences SRHR needs, while it also recognizes and incorporates really important contexts like criminalization and economic power to push beyond just a health and rights frame to get to some of those missing justice pieces. Next slide. I'm not going to read the Lancet-Guttmacher definition because so many of my colleagues have gone through it, but it's really important that this is a US advocacy document that roots itself in this definition. So the Lancet-Guttmacher definition is both enshrined in the blueprint and reflected throughout and built upon for the very sort of specific advocacy context. And this definition obviously has really important global resonance, and the sexual and reproductive health and rights language itself has always had a broader movement understanding and advocacy globally than it has within a domestic context in the United States. This sort of rooting the domestic blueprint in a global definition hasn't always been true, and it's a really tangible result of civil society working to align the United States into the world with shared language. From ICPD to Beijing, US has oftentimes seen itself as not held accountable domestically to these kind of international agreements. And this is a pretty important advocacy step for domestic and foreign assistance leaning advocates to have a shared definition and understanding of sexual and reproductive health and rights. Next slide. So principle 1 has a number of really important pieces in ensuring sexual and reproductive health care is accessible to all people. There's domestic asks around cost. In foreign policy, it highlights the need to prioritize and integrate SRHR, asking Congress and the administration to expand access by fully funding international family planning programs, UNFPA, and the other global health and gender equality programs. Also really asking for very clear US leadership on prioritizing and integrating SRHR in all settings, from the UN to humanitarian emergencies. This principle 1 also enshrines access to abortion care domestically and globally, and the importance of protecting it and expanding it. In addition to the US supporting decriminalization of abortion worldwide, the blueprint calls for an end to the Helms Amendment, which unjustly restricts federal global funding from covering abortion care, and also asks for the removal of the Hyde Amendment, which similarly restricts abortion access for women and girls and people who are pregnant in the United States. It also asks that the federal government ends harmful policies that restrict access to providers, including the existing domestic gag and global gag restrictions that block providers from participating in federal programs and global health assistance if they furnish comprehensive care to their patients. So principle 1 enshrines a lot of really important access issues and removing a lot of the barriers of access that are enshrined in US law and policy. Next slide. Principle 2 is ensuring discriminatory barriers to healthcare are eliminated. It includes global and domestic healthcare entities and insurance plans, requiring them to have robust non-discrimination protections for all patients without exception, and also includes some very specific policy asks for the US global AIDS programs, including ending the abstinence only until marriage funding, restrictions on how organizations can engage with sex workers or advocate or speak about their health and rights. So removing some of those discriminatory conditions attached to US money is enshrined in Principle 2. Next slide. Principle 3 is our ensuring research and innovation, advancing sexual and reproductive health and rights, health rights and justice. And this is a principle enshrines so many important pieces of health system reform in the United States, needing to prioritize sexual and reproductive health and rights and equity, but also asking federal policymakers to invest in research and development to improve sexual and reproductive health care, and asking policymakers to restore scientific integrity and transparency to support all activities, but particularly highlighting those that affect sexual and reproductive health. So much of the conversation and that's happened in the United States in the last 3 years has been some real attack on the veracity of evidence and needing to ground policies and programs in research and evidence. And the advocacy community sees that and being quite explicit about the need to rebuild that kind of trust, a very important and new principle in the blueprint. Next slide. Principle 4 is ensuring health, rights, justice, and wellness for all communities. This is a really important reflection of all of the pieces that Marcella was discussing in reproductive justice, and many of the pieces that are excluded from reproductive health and rights discussions. Very explicitly naming policies that are barriers to health, rights, and justice for all communities, including asking policymakers to foster economic opportunity for all families, policymakers ensuring all communities are free from violence, policymakers needing to promote and ensure integration of the social determinants of health into the provision of health care, and asking policymakers to invest quite explicitly in programs that promote health and well-being and advance gender equity. And while this is a bold, forward-looking vision, we are also very prescriptive about which US programs need to be fully invested in the existing frameworks that we have, including Medicaid, Title X family planning funding, the Centers for Disease Control and Prevention, fully investing in UNFPA, the President's Emergency Plan for AIDS Relief, or PEPFAR, and Global Fund. Next slide. The final principle within the blueprint is Principle 5, ensuring that judges and executive officials advance sexual and reproductive health rights and well-being. The structural sort of frameworks of the US federal government need to include a real understanding of SRHR and how those rights intersect with other rights. This particular principle has a huge impact domestically and globally, and the blueprint is quite clear about what type of judicial nominees and executive nominees the president should be putting forward and that the Senate should be confirming. And this is the sort of very important process principle that can have a huge impact on generations to come, both in the United States and in the programs that the United States supports globally. As we build federal advocacy for the future as civil society organizations in the United States, reflecting on our own role in promoting sexual and reproductive health rights and justice in the United States and around the world because of the major foreign policy and foreign assistance blueprint that the United States has, we're trying to set an agenda with the Guttmacher-LANCET definition of sexual and reproductive health and rights, but that includes how inextricably linked it is to economic justice, voting rights, immigrant rights, LGBTQ liberation, disability justice, and the right to community safety and racial equity. I think all 80 organizations are very proud of a document that is both visionary and extremely practical and takes this much more comprehensive definition of sexual and reproductive health and rights and expands it with a lot of the structural needs that we see reflected in the United States and in the United States interactions with the world. Thank you.
This is Patty again. Thanks so much to all of our presenters, which gave us a lot to think about and a lot of frameworks to consider while we're moving forward with U.S. domestic and foreign policy. And I want people to, I invite the audience, everyone who's here, to put questions in the question box. I'll read them aloud for our panelists, and we'll continue that way. And while our participants are writing questions or thinking of questions, I'm going to open up with one for all of the panelists, particularly following up on Marcella's presentation. And I'm wondering what you think of this. How do you think the U.S. reproductive justice framework, and in particular, I'm thinking of the RJ approach to intersectionality, how can that contribute to our work globally, both on U.S. foreign policy and in the global domestic or the global policy advocacy that we do? And I'll open up to everyone. Perhaps we can start with Anu or others if you have comments.
Yeah, sure. Thank you. Thanks, Patty, and thanks to the panelists for their presentations. Very interesting. You know, I think the reproductive justice framework, as Marcella described, does a really great job of inserting power into the conversation. You know, it has a very strong and grounded power analysis, whereas the global frameworks tend to talk about barriers. So, you know, the Guttmacher-LANCET report, as other previous reports have done, has talked about sociocultural barriers, economic barriers, et cetera. But we haven't really rooted the global health work in a power analysis. And I think that is something that we probably not just can do, but should do. And when I think about our sector, you know, I think about how we are grappling with not just the legacy of colonialism and what that means in many of the places where we're active, but also the ongoing relationships between donor countries and recipient countries and how that plays out in terms of power and other aspects of development. So I guess I think that is a very important aspect of the reproductive justice framework that we in the global working in the global space could learn. And then the second point I would make is just to echo what Marcella said around the realization of rights. We have been extremely good at enumerating the various rights that people are entitled to from the Universal Declaration of Human Rights on down, but the realization of those rights and the monitoring of those rights is something that I think we could do more on. So I think those 2 points are things that we in the global movement could definitely learn from the RJ movement.
Before I get to the other questions, any other panelists want to answer?
Hi, this is Jane Bertrand. Anu, I'm just curious about your saying we haven't focused on the power analysis. All of the attention at ICPD on gender equity being at the root of future progress, would you not consider that to also touch on the power analysis dynamics?
No, it certainly does, but I think the RJ framework has a much more broader approach to thinking about it. You know, the intersectionality that was referenced, the look at environmental issues, and you know, the contextualizing of rights and power in the broader socio-political context is, I think, sometimes not as well developed in our work as it has been in the RJ work.
I'd just like to say kudos for that exceptional video. Rarely have I seen something that's so entertaining and that passes along so much information in a very readable, watchable format.
Okay, I'm going to read a question that we got from our participants. We all know that these frameworks are important to envisioning SRHR change and improvement because we work in the industry, but how do we employ language like reproductive justice with lawmakers and the public who don't view abortion as a right, let alone understand the racial nuance within reproductive justice? And I'll open that for any of our presenters who want to take the mic.
This is Marcella. I'll at least venture into that. I think that one of the things that we've had to do in terms of talking to policymakers about reproductive justice is to do it in the same way in which we frame outreach and mobilization of women of color, is to talk about the intersectionality pieces and how issues dealing with this power dynamic that was mentioned earlier, that is empowering people to actually make decisions about their own lives and looking at all of the pieces that impact them. We did a briefing with the Progressive Caucus staff, for instance, on intersectionality and how what they were talking about in terms of their progressive framework, what they were leaving out or what they were encompassing, and how to do that. And I think that it is important that we approach things. The problem we have with abortion rights, for instance, is that people have drawn lines about how they feel about it. And one of the things that we did and what we were able to tell folks in terms of our polling was that even people who self-identified as being very religious, still thought that the empowerment argument, people being able to make those decisions for themselves without having policymakers or really egregious laws dictating to them, because there was this history of other people being in control of Black women's bodies for so long that they even said, even though they might not have an abortion for themselves, they did not think it was their right to tell other people what to do. And it's looking at things from that perspective about everybody being able to make decisions because they are probably the best to know the lived experiences of their own lives, and being able to do that.
Okay, thank you very much. And that reflects a little bit two questions that we have that are similar. I'm hearing a lot of questions or seeing a lot of questions around practical solutions and really operationalizing the frameworks. To read two different questions, the first saying that the presentations were excellent and wondering thoughts on how to localize these policies, frameworks, and findings in a way that resonates with local communities and the needs and wants they express in their daily lives. And a second related one that we haven't seen, I think Marcella, you addressed this a little bit in your last answer, but an interest in practical solutions. How are these recommendations? How are they practical? How can we make them make a difference?
So I think this is Anu. One of the questions I think is around exactly what you said, Patty, about how do we make these frameworks more relevant? Is that correct? Am I understanding this correctly?
Yeah, and what I understand the questions to be asking is how do we make them make a difference?
Yeah, so one of the things that happened after ICPD, and again with the Guttmacher-LANCET Commission report, was that it was used as an advocacy tool by many organizations, civil society organizations, but also within governments to organize their own development plans and policies, and indeed their funding allocations. So, you know, we have seen that these documents and these frameworks are used to organize at least the funding and budgets of donor organizations, and similarly within countries, you know, very often ministries of health, ministries of gender will use these international global frameworks as a reference point for organizing their own work and their own funding. So, you know, yes, they are very aspirational, and they're certainly not something that any one country or location has been able to do fully and completely, but the aspiration does inspire action. And it's up, you know, I think it's very often up to civil society to really use them and use these frameworks for advocacy purposes, both within national governments, but also at the international arena. I'm sure my colleagues have other things to add.
Hi, this is Jane.
Okay, Jane.
Fine. A couple of things on this. On the commission, one of the contributions was to be very clear on, is there a package of interventions that one would propose for use at the country level? I think one of the problems with ICPD was many of the topics were introduced, but at the end of the day, what is it that country X should take away from that in terms of being able to present a full range of interventions? Another important part of what the commission talked about was this idea of progressive or phased application. Not everybody can do everything. And I was talking from having worked in a country that's one of the poorest in the world. How do they that are struggling with so many problems try to embrace this very broad and comprehensive agenda? And the response to that was, figure out the priorities, recognize you cannot do everything on day one, but have the vision that this is a comprehensive package is what one wants to work towards, even if it's going to be a phased-in approach. And just one final point in terms of practicality. How do you get people to take this definition, this vision, into account in its practical everyday work? The DFID, the British Development Agency, in its call for proposals, had language that required the organization soliciting these funds to take into consideration and to base their proposed approach to the proposal on what was this definition. So I think that's an example of how one can try to go from words on a page to actions at the field level.
Thanks very much. Marcel, comments?
I think that that what was just said was close to what I was going to say, is that it takes civil society to really push policymakers and administrations to take a vision, which is what I think the Guttmacher-LANCET Commission has come up with, a vision of sexual and reproductive health and rights, and really then make it into a reality within their own community. And if you push the policymakers who have to make these decisions about where to put the money, and they're hearing from civil society and people who are most affected by this issue, then the money gets put to that. And if nothing else, we can see it in this current conservative administration in the United States around climate change, for instance, where the philosophy that climate change doesn't exist, plus funding being withdrawn from the CDC climate change and things like that, equals policies. And that's what this is. We've got this great vision, and it is up to all of us to actually figure out how to move policy people at all levels, both domestically and globally, to put the money where those policies should be in order to implement those policies.
Thanks so much. And then I see one final question and I'll read the whole thing aloud. While ANU mentioned the US is an aberration in terms of global and sexual and reproductive health progress, our international policies and fundings do have enormous influence on access to so many countries around the world. And I know Change has one. This is my own commentary. Change has an example of the following, but I'll read it aloud. Can you kindly provide some recent collaboration or examples of how activists in the global North and South are fighting for some of US policy and funding barriers created under the Trump administration and early administrations that affect women globally. And first to mention that Ipas has done some of this work in bringing our country staff and partners to Washington in advocacy work to talk about the impact that they experience in the field from US foreign policy, in particular the global gag rule and the Helms Amendment. But I'll turn it over to the other panelists for examples of global North and South collaborations to fight against the Trump administration and other anti-SRHR administration's policies.
I'm happy to jump in here. This is Bjorn from Change. This is a core part of what Change does, is try to make sexual and reproductive health and rights in U.S. foreign assistance reflective of the actual needs and goals of people in countries receiving U.S. foreign assistance. So I actually have colleagues here in Washington, D.C. right now from Tanzania and Malawi and Zimbabwe who will be speaking for themselves to members of Congress and parts of the administration about what's going well in HIV prevention and integration of SRHR services, and what's being impeded by US policy, and making sure that they have an opportunity not to be sort of distilled through our voice, but speak for themselves about the impact of US policy. And this is something we try to do as much as possible. And of course, we are dedicating an enormous amount of our time to the global gag rule. It's sort of the policy that's devoured the global health system because of Trump's expansion to all of global health assistance and the ways that it disrupts and destroys relationships in health service delivery and organization priorities and national priorities. And that's something that so many of the groups on this webinar, but also engaged in the blueprint process, have been really sort of working on how do we, as US-based organizations, hold our own government accountable to the policy, as well as try to mitigate the harm of the policy by helping organizations navigate it, and do advocacy in the United States at the congressional level to try to end the policy once and for all.
Thanks, Bjorn. Any other panelists with comments on North-South collaboration to end harmful U.S. policy?
I was just going to add one thing. This is Anu. So certainly the collaboration that Bjorn mentioned and Patty mentioned are important. I do want to mention that there are a number of European organizations that are also active in this arena. So the advocacy of the European governments and the European civil society is very important and should not be overlooked. Many of those European governments have extremely progressive policies and actually actively support sexual and reproductive health and rights, oftentimes in direct contradiction to what the U.S. government wishes. So I think that is another important spot or moment for advocacy. And also we're seeing the Canadian government emerge as an important partner as well. So, yes, it is extremely important that we as American organizations work with our colleagues from the Global South to counter the US, but there are other variables and factors as well that we can use to pressure and push the US administration.
Thank you, Anu. I'm going to read another question, and this one is from Burundi. In Africa, especially Burundi, where we are doing actions to promote sexual and reproductive rights, in most cases we face problems related to sociocultural and traditional barriers. So looking for some strategies to implement to tackle the problem. And I love this question because it really reflects some of the on-the-ground work that needs to be done. So any advice from the panelists?
Hi, this is Jane Bertrand, and since I work in the neighboring country of the Democratic Republic of the Congo, I feel I better answer this question. In our own work, where we also face, as you can imagine, many barriers and cultural norms that would go against some of these practices, I think one way is to try to better understand some of the underlying why is the barrier there? And what is there about traditional beliefs that in fact might help to advance the agenda despite other constraints? The most obvious example is in promoting family planning, which is what we're involved in doing. There is a very widely practiced naissance désirable, the culturally accepted traditional view of the importance of spacing children, not brought in by some Western people that thought this was a good idea, but what has for decades been traditional practice, and trying to build off that. That is an easy example. I would say much harder is, for example, the very strong male dominance that we find in society, where actually you lose rights when you get married and your husband then has the greater say in what decision making regarding reproductive health. So again, getting the issues out on the table, helping women to understand that there are even alternatives to what the accepted day-to-day practices are. Again, I'll put another family planning example on the table. Many people are against family planning until it comes to their village or to their section of the urban slum. And when it becomes accessible, then it's time to really focus in and say, hey, wait a minute, maybe this is a good idea. So recognizing and trying to be as culturally sensitive as possible, while at the same time pushing the envelope to provide access to what was previously unacceptable or not part of the cultural terrain would be my answer to that question. It's an uphill struggle, but good luck in Burundi.
This is Bjorn from Change. I think one of the things that can be really helpful is to set meaningful and not gigantic objectives. In the policy blueprint, we sent out something huge, but all of those things are going to be broken down into individual advocacy strategies and plans. And we want to have a collective vision of how they all fit into the world that we want to create. But we're not going to get, a new, 300 members of Congress to completely buy into our vision overnight. And so breaking it down into some discrete advocacy objectives, and doing real power mapping around those objectives. Who holds the power? What are the type of things that might persuade them? It may not be the whole vision, but it might be maternal mortality. It might be that their policymakers used to be a nurse, or their mother was a nurse, and you can start from a health systems delivery point of view. I think this is a really important place to not exceptionalize the United States. The United States has a very strong culture and a set of very strong cultures and cultural narratives that it also has to overcome in its domestic and foreign policies. Some very conservative, some very regional. And to be successful in advocacy in the United States, you have to do the same sort of assessment of what are entry points. How can we introduce shared language, but not expect people to sort of start with a wholesale buy-in of the Guttmacher-LANCET definition, but start from places where they may have more comfort or familiarity.
So we have a few minutes left and we're out of questions. So I'll open it up if any of our panelists want to have a final word or comment.
This is Marcella. I just wanted to add to what Baron said. I think it is important for us to, when we're looking at the United States, to not give the impression that we have all the answers, because if we had all the answers, we'd be doing much better in our policies. But we also need to look at this definition as possibilities of things that we can do, at least with some policymakers, because some policymakers have been talking in the same fashion as this definition for a long time. And for us to be able to, and the blueprint, as she mentioned, has done a lot of this, has said a lot of the, look both at domestic and global policies, at least how the US impacts global policies through its funding. And so we have that as our own blueprint. And now we have the Guttmacher-LANCET Commission definition, expanded definition, that I think we then incorporate into some of the work that all of us are doing. And as I said, for our organization, then we overlap the RJ pieces in there as well. And I think that we have a good relationship between those who do domestic and global policy, but we just need to link them better together and really clearly articulate it to people as we go to the Hill and talk to them, and as we go to agencies and talk to them, to talk about them as this linkage and not to separate them so much.
Well, I would love to end on that note, that we really need to continue to link these different frameworks as we proceed on our advocacy. And I want to thank Anu and Jane, Marcella, and Bjorn for this wonderful presentation and conversation. And we have a lot to think about. And to all of our attendees, we had over 150 people from all around the world. We'll send out the recording of the webinar for those of you who have colleagues who might not have been able to hear it. And thanks again to our partner Change for moving this forward. And we look forward to seeing you next time.